Right, can we just go through them, see if there's any areas people don't agree with? Page 1, that's all right. Well, it's page 3. Page 4, anybody? Page 5 and page 6. Right, so we just can forget those for now and move on to the financial update. And who is leading on that one, please? It's you, Andrea.
I am. Yes, yeah. I am. Yeah.
Would you like to go ahead, and do we need a split screen, or is everybody, or have you got any documents to put up?
Yeah, there's the slide deck. I'm not sure who.
Okay, I'm in now, Pat.
Thank you, Susan. I'm just up to the financial update.
Well, carry on if you want to.
No. Well, Andrea will take it, do the financial update, then you
okay.
finish off. Okay, thank you.
So could I just check, Peter, are you going to share the slides that we circulated?
Yes, I can do. Yeah, I'll just do that now.
Yeah, thanks, Judith.
Thank you. Well. It was quite a lot to ask Andrea to remember that and recite it.
Just bear with me a minute or two. I'll load it up.
Thanks very much.
You all right, Susan?
Yeah, I am. Thank you. I've just come out of another Teams meeting, so sorry for being.
I know it's not a problem.
Going from Teams to Zoom, it's just knocked me back a bit, but finally did it.
We do more actually with Zoom, don't we, than we did, just going to meetings. We always seem to be where they're all coming.
Yeah, we get more meetings now.
Yeah, building up.
So we're up to financial update.
Yeah, Peter's just doing the split screen.
Oh, thank you.
So could I just mention that there's 3 of us on the call from Pennine Care. Andrea's going first with the financial update, and then I think she's got another commitment, so may have to leave the meeting. But I'm happy to pick up anything that's outstanding at the end if we have some more questions. And we've also got Fiona here who's going to join us in terms of some workforce updates, and I'll pick up the general COVID at the end if that's okay.
Yeah, thank you.
Fab, thanks.
Thank you. Thanks, Peter.
Can you all see that?
Yes.
Yeah, thank you.
Yeah.
Thank you.
Can you make it a little bit bigger, Pete? If you can't, you can. It's okay. We can manage with that. Oh, yeah. Thank you. Yeah. Is everyone all right? Can everyone see that?
Yes, lovely.
Thank you.
Yeah, fine.
Yes, thank you.
So it's over to Andrea, is it?
Yes, thank you. If we could go to slide 3, Peter, please.
Yeah.
I'll just move my gallery view, then I can see the slides. So I guess just by way of update, so I came to you, I think it was in January, and explained the fact that in 2021, from a financial position, we've been under what we call a national command and control regime. And that was for the first 6 months of the year, all trusts were given the necessary full financial support to deliver a break-even position. So all of our costs, if you like, were fully funded. And then for the second half of the financial year, we moved into a Greater Manchester system envelope position. And as part of that system envelope position, Pennine Care's target surplus was 1.25 million. So we've reviewed that surplus along with all of the providers in Greater Manchester, and we've submitted a revised forecast outturn, which shows an improvement to a surplus of 4.8 million. So that does sound, obviously it sounds quite a significant improvement. It's mainly driven by those 3 key things that I've listed in the slides. So we've had a higher level of efficiency savings than what we were expecting in the second half of the year, and that's mainly due to vacancies that we haven't covered. Some of that within our corporate services function, as we are going through a corporate redesign programme. So those vacancies have been held pending that redesign programme. We've also spent significantly less on COVID, on our sort of additional costs of delivering COVID, if you like. Sorry, Peter, I've got a big black box in the middle of my screen now, so I can't see the slide. I'm not sure if that's just
sorry.
Likewise.
It should have gone now, right?
That's fine. Thank you very much. Thank you. So yes, from month 7 to 12, we were given an allocation from Greater Manchester of 5.8 million in terms of what was our fair share funding. So it's not necessarily what we expected to spend, but it was our fair share funding from the centre for delivering the cost of COVID. We've not spent that full allocation, and that's largely due to recruitment challenges, given the non-recurrent nature of the funding that we've received, particularly for service development such as the 24/7 helpline. So what we've had to do is use a lot of our existing staff to cover some of those services as best as possible, because I'm sure you'll appreciate it's really difficult to recruit to staff on such short-term contracts, and temporary staffing is obviously of there's limited availability. Obviously, as well, the third key factor in that is that given the fact that we are, we're moving through various waves of the pandemic, there have been changes in the timing and implementation of some of our sort of prior approved investment decisions. So things like e-rostering, where we've had to delay some of that implementation, for example. In terms of capital, so that's our revenue position, sorry. In terms of capital, there's no change from what I reported last time. We're still projecting that we'll spend the full envelope of 10.24 million, and we are, as we said last time, that includes significant investment into informatics, device replacement, the rollout of the electronic patient record, and our major estates programme around the eradication of dormitories. So it's probably just to note, I guess, that whilst we are reporting a surplus position, that is driven by the fact that we've received a significant amount of one-off money. Sorry,
Can you turn your phones off, please?
That we've received a significant amount of non-recurrent investment, and excluding that central financial recovery funding that we'd expected to receive, we did actually have a planned deficit of circa 10 million pre-COVID. So I guess it's just to highlight the point that there is still quite a significant financial challenge at Pennine Care, and that will obviously that will become more apparent as we move into 21-22. So if we can just move on to the next slide, Peter, please. So as a question that you asked me last time that I promised that I would bring back to this meeting, you raised a question on temporary staffing and agency and bank staffing. So I've just included some information there for you that you can see. There's some trend information there in terms of how much we've spent on agency and bank compared to for the first 10 months of this year compared to the first 10 months of last year. So our bank staff has continued at a similar trajectory, but our agency spend has been quite significantly lower, if you like, than what we'd actually spent in 1920. That's mainly driven by the fact that obviously during the first half of the year, some of our services were either stood down or they operated on a very different basis, and that gave us flexibility to redeploy staff, and that includes corporate staff being redeployed as well to support some of our frontline services with administrative duties. And we also had a number of student nurses join us. So I wouldn't say that that's necessarily what the position would be as we come out of the pandemic, but certainly that's the level of agency staffing that we've seen this year. If we could move on to slide 5, Peter, please. Thank you. So just a bit of a forward look then in terms of where do we think that we're heading for 21-22. I think I updated last time, there hasn't been really much movement in terms of the planning process for 21-22. We are still waiting for information from the centre regarding what that planning process and what the guidance actually is. So we haven't yet received our system envelopes, again, if you like, for Q1, and we still don't have any information of what that will look like beyond Q1. You asked last time, again, just to follow up last time, you asked me just to highlight what our trust operational budget setting process would be. So obviously there's the national planning process, but aside from that, we are still working to set our own operational budgets. And you asked me to just give you an update in terms of how do we do that. So just very briefly, we review our existing budgets. We work very closely with our budget holders to consider future service provision, and we look at any changes that might need to be made to our existing budgets for things like changes in rotas, skill mix, etc. but then we also consider any sort of unavoidable cost pressures. So anything new or in year that's arisen that we haven't budgeted for. We then look at the cost of inflation. So that's pay increases, pay awards, national insurance and pension contributions, and inflation on other goods and services, so lease agreements, etc. And then against that, we look at, ordinarily we have a contracting round with our commissioners who will give us a national uplift for inflation. So they have a prescribed uplift that they give us for inflation. It doesn't cover the full cost of inflation. There is always an assumed level of efficiency. And for 2021, pre the pandemic, the trust level of efficiency would have been 1.1% was the national requirement, but then we also had to deliver an extra 0.5% because we're a trust in deficit, and that would have been part of our recovery plan. So nationally in 2021, pre the pandemic, we would have had a minimum efficiency challenge of about 1.6%, which equates to, I think, just about £3 million. We then also have discussions with our commissioners around service developments. And as some of you may know, commissioners are mandated to invest in mental health services. So there is a set amount of money from their allocations that they have to invest in mental health services each year. That is a minimum requirement that they have to invest, but quite often that becomes, because of their competing challenges and their affordability gap, that actually becomes the cap on the investment that we receive. So we work with our commissioners to think about where do we need to invest that mental health investment standard, and then obviously what the workforce requirements are around that. Once we understand all of those component factors, we then basically have to look at what's the difference between our income and expenditure. So what's our calculated budget? And then ordinarily we are given almost like a target control total, if you like. And in the past, that's been given to us as it's been called many things, but more recently a financial improvement trajectory. And that's what does our financial position need to be so that as a trust we can access the system support funding. So last year, pre the pandemic, that target control total would have been the deficit of just over 10 million that I mentioned earlier on in the presentation. So the trust's budget deficit, we had to deliver efficiency savings to bridge any gap between those, sort of inflation and contracting discussions with commissioners to deliver a budget deficit of 10.8 million. And that's what we would have needed to achieve to be able to access £10.8 million worth of system support funding. So that's the process that we go through each year annually. We are still following, aside from the national planning process, we are still following that process within the trust at the moment, obviously because it's important that we have an operational budget that our budget holders can work to as we're going into 21-22. And we are just at the process of starting to have discussions with our commissioners, because even though we don't have the national planning guidance, we know that they will still have to invest in mental health services going into the new financial year. So we're having those discussions now with our commissioners to say, could they give us an indication of how much investment that is likely to be, and then a shared conversation around what are the priorities for both commissioner and provider. Okay, so happy to take any questions. I hope that covered some of your questions from last time.
You're on mute, Susan. You're on mute, Susan.
So if anybody wants to speak, it might be better if you just put your questions in the chat, whether the comments or they are questions. And I can see one. If you can just help me with this, Peter, because obviously I don't want to miss anybody with the hands up, but I think the first one there is, you've not got your name here on your screen.
Councillor McLaren.
Oh, Councillor McLaren, thank you. Go on then, Councillor McLaren.
Okay, thank you, Chair. Andrea, thank you very much for the presentation. But have you actually presented a budget to your governors?
Not at the moment, no, we haven't. We are in the process of drafting an operational budget for 21-22, and that will go through our internal governance process over the course of March. Obviously, there are still, we haven't had the planning guidance, so there are still quite a lot of gaps in there at the moment. So, for example, as you'll be aware from the press, the NHS, the pay award hasn't been settled, etc. So we're in the process of doing that at the moment, and we'll be taking what we deem to be a draft budget through our internal governance during March.
Right. So there isn't an indicative budget that you could have shared with us this morning.
No, I'm sorry, no, not as yet.
The purpose of setting the meeting as this far into March was for that reason, so that we would have a look at the budget that was actually going to be presented, if you like, or had been presented and approved by governors. Your governors.
Yeah, absolutely. Sorry, Judith, do you want to come in?
Okay, can I just
apologies,
say,
yeah, it was just to,
if you just go through the chair though, don't just invite people.
Sorry.
We're gonna get lost.
Okay.
So yeah, I'm okay, Judith.
thanks, sorry, I was trying to wave. Yeah, I imagine, I think the thing is that the whole of the NHS is still under a command and control financial regime, which has superseded the normal running arrangements for the NHS. So the timing is out of our control. So apologies for that. I think that's not uncommon because we're not just able to set the budget yet.
Right.
You okay with that, Councillor McLaren?
Not really.
No, well, I think we all expected that other budget, but tiring and testing times, isn't it? So I think we're going to just have to go with what we've got for now. But I'm sure once Andrea's got that, and maybe they can be presented at the next meeting. Councillor Pat Dale, do you want to speak? Pat?
Thanks, Sue. Thanks for the presentation, Andrea. When I went through, because I read it before the meeting, obviously, and when you comment on it was about efficiency savings that were mainly due to the high rate of vacancies, although you didn't actually say high rate, but I got the impression because we haven't got enough people in the system, we've actually made savings. Now, my concern is that if COVID, and we know this is the case, COVID is going to put huge pressures on providers of mental health, and having, a level of vacancies which is so high that we're actually making savings because of it. I'm just not happy with that at all. Andrea, do we actually know at this point in time what the level of vacancies within the trust is?
I don't have the information to hand now, but again, I can find out for you. I've not brought that information with me today, and I wouldn't like to say. What I would just say is, although, as I said in the presentation, within corporate services, some of those vacancies have been held pending the corporate redesign. Within our clinical services, those vacancies aren't held. That's due to, it's almost, so it's not as though we hold, we sort of hold back and delay recruitment into anything. Some of that is just natural timing of some of the recruitment challenges that our clinical teams have faced in terms of how they recruit into those vacancies. So when we first assessed our surplus at 1.25 million, I think we were probably a little bit optimistic around how quickly some of our clinical teams could recruit into those vacancies. And that's what's driven that sort of change, if you like, in the profile.
So compared to this time, say, last year, is the vacancy rate higher or lower? Would you be able to shine some light on that?
I don't have the information to hand, Patricia, I'm sorry, and I wouldn't like to speculate because there have been such significant changes in our service offer over recent years. So obviously we've had the transfer of community services, etc. So it's something I would prefer to go away and find the information and bring it back rather than give just an indicative position at this point.
And I think that would be really helpful to us because obviously it is a huge concern. I mean, I'm sure you can appreciate that. Thank you.
Yeah, okay. We thank you, Andrea. Thanks,
I think, Pat. Chair, I think Judith wanted to come in on that last point as well.
Yeah.
Thank you. Yeah, The workforce challenge is significant, as you say, right across the NHS and in the North West and in mental health in particular. So we're working proactively with Greater Manchester Mental Health via the GM Mental Health Executive to look at any potential around joint recruitment and some bigger campaigns. We're also working to look at redesign to say, are there some different skill mixes, some new roles that we can create, which will help us with some of that further spread of expertise and hopefully bigger recruitment numbers. We did a bit of work for board this month to look at impacts of COVID on availability of workforce. So we need to check the exact figure, but we haven't noticed a significant exacerbation of vacancy challenges. And what we have noticed is we've been quite successful in recruiting bank staff. So the fill rates when people try and book a temporary member of staff to cover shifts, that the fill rates are quite good and we're not experiencing any problems at the moment. But longer term, yes, we do need to recruit to those vacancies, especially as there's a lot of money coming out for mental health services from the long-term plan. And I think nationally there's a recognition the workforce isn't necessarily there unless we do some redesign work.
Thanks, Judith.
Thank you, Judith.
Councillor Wright wants to speak, Chair.
Yeah, I think we've got Councillor Hamlet who had his hand up first. Sorry, Councillor Wright. So if we go to you first, Louis.
Thank you, Chair. Question for me regarding slides 8 and 9. And it's just timely, as you mentioned, the bank staffing and staffing pressures. There's also the health and wellbeing support. As lockdown pressures are now coming to an ease, the challenges for mental health and the demands on mental health services will likely rise. And of course, the challenges therein for your staff will then rise also. My worry, therefore, is do you have the capacity to meet those challenges in the future towards the end of this year or for the rest of this year? And also, will you also have the enough staff members to also continue that important continuity when it comes to people's personal mental health throughout the rest of this year and possibly, if required, into next year as well? Thank you.
Are you okay to answer that, Andrea? Or Judith? Is it you, Judith? Sorry.
Yeah, probably. I think you're right about the anticipation of considerable increase in demand for mental health services. When you look at what's happened today, that hasn't yet materialised in terms of numbers. It's more manifested itself in terms of increased acuity and complexity of presentation. So if we look at the referral rates into our services for out-of-hospital services, with the exception of child and adolescent mental health services, referral rates haven't really recovered to pre-COVID levels, but the number of referrals that are urgent is greater proportionally than previously. So fewer people in total, probably linked to GP access, but the people who are appearing in service are usually more poorly and slightly more complex. Now at the moment, because we've managed to change some of our service delivery models, so quite a lot of telephone conversations, remote consultations, and one-to-one where people's needs require it, we've actually been able to meet the current levels of demand because we've become more productive in a way in the time. But there is an anxiety about future demand. There's some national money being made available. I think I'll wait for Andrew to nod. I think there's £500 million being made available non-recurrently this year, and we're waiting to see what percentage of share we get in the North West, and then obviously down to Pennine Care for that. But one of the challenges is that there isn't any hard modelling or hard information that would let you accurately predict that demand. So for the acute sector, it's not easy, but it's possible to model the impact of the delays to, for instance, elective surgery, and you can then route that up through the system throughout patients' theatre time, ICU, etc. Just knowing that people are likely to have more complexity and more people be impacted doesn't really let you model the numbers very well. So nationally, there's a few pieces of work going on because we've done some work in Manchester just to say, what if things went up 5%? What if it went up 10? And it's less than ideal. And then actually, we did that part way through the pandemic, about September time, and that demand hasn't materialised, except in children's services where there were peaks associated with schools returning after lockdown. So where there is some non-recurrent money that's going to come our way, we're trying hard to look at some more sophisticated modelling, but I think it's recognised as a pressure in the system. There will be some sort of pent-up demand that is likely to manifest itself, not only in this year, but possibly beyond. So it needs to be a key part of planning going forward. We've also across Manchester, the mental health exec, do quite a bit of work with the VCSE. We did a joint piece of work early on about increased demand, because I think there was a bigger increase in voluntary services than in our services at the beginning of the pandemic. And so we're hoping to do that modelling across the system and then work out the best way to respond. But I share an anxiety about that, I just haven't got the answer.
Okay, thank you, Judith. You're okay with that, Councillor? Yeah?
Yes.
Okay.
Thank you.
So I think once you've got that model, if you could make it available to us, Judith, maybe not at the next meeting, but as soon as you can, if you could get Peter to email that across to us, so that as soon as you get that, we can have a look at it and see whether, and then we can measure it then to what you've talked about this morning, and see whether those tally up, and see if there is still going to be some gaps. Is that okay? I
can share the modelling. It isn't complete yet in GM, but I'd be happy to come and share the principles. I think it's certainly less than perfect in terms of any accurate prediction of demand. And I think it's an iterative process that we'll be working on, but happy to share it, yeah, of course.
Yeah, that'd be brilliant. Thank you. So it's Councillor Wright now, John Wright.
Thank you, Chair. My question's about using student nurses. And the first one is, are you still using them? The second one is, what is their rate of pay in relation to qualified nurses doing a similar task? And thirdly, and perhaps most importantly, does this experience that they've gained or are gaining give them some kind of enhancement when it comes to the award of their final grades as nurses? Thank you.
I think if it's okay, I think Fiona may be able to answer most of that question. In terms of their pay was funded, so we were giving the student nurses, and I believe that their pay costs were fully funded when we received them, so we didn't incur any cost for those student nurses. But I think Fiona will be able to talk about what it meant for the nurses themselves in terms of the completion of their qualification.
Thank you.
Thank you.
Thank you, Andrea. So the nurses that we employed during the last year were students that were in their third year of their course. And what we were really mindful of was that they didn't lose their placement activity during their third and final year of their course. So it was a bit of a dual benefit that those third year students were able to continue in their placements, but we employed them as nurses during that period. So they were, as Andrea says, fully funded. They were paid the same as if they were a nurse, so they didn't have a detriment compared to other nurses during that period. And there was a real benefit in that it enabled us to work really closely with those students during that period, and quite a lot then went on to employment with us because they'd experienced working with us over a longer period of time. So we're able to understand better as an organisation what we were like. Does that answer the question?
Yeah, it does. I was just concerned that they would suffer some kind of financial knockback, if you like, and there might be an impact in their progression into full-time nursing.
No, so it was particularly the third year students, because that's where it was understood the greater impact might be around them being able to complete their degree programme. So it was a benefit both ways, that they were able to continue on their progression with their course, but also it allowed us to be able to fill some of the vacancies by paying them as nurses during that period.
Okay, thank you.
Okay.
Thank you, John. Councillor Surjan.
Thank you, Chair. My question is sort of like a follow-up to the previous question, but it's more focused on volunteers. So I'd like to know what kind of support and help the volunteers have. Obviously, we know that the PM had a massive target of 450,000 volunteers for the NHS, etc., etc. So I'd like to know the number of volunteers that we had and the kind of support that that was provided for them whilst they volunteered. Thank you.
Is that Councillor Surjan? Do you mean like as in the funding for them, how it's affected the?
No, not the funding. More the kind of the perhaps the more mental health support that they received, the training that they received, any supervision. Because you know, obviously the sheer number of people that signed up to volunteer, which was admirable. But I just want to know, as a trust, what kind of support and help did we offer them? If that's okay, thank you. Hope that's clarified.
Yeah, that's fine. Has anybody got the answer to that, or is that not for this session? Because this is more about the budget. It might come up that again further down the line, maybe when we talk about the staff health and well-being. It might come up with that. We could probably ask that question.
Yeah, that's fine, Chair. That's fine.
Is that okay?
Yeah, that's fine. Thank you.
All right then. So is everybody okay with that? And nobody else wants to say anything? Councillor McLaren. You're on mute. You're on mute.
Keep forgetting. Anyway, sorry. Thank you, Chair. I wonder if we could just go back to the budget. We appear to be in a situation where we don't appear to have an outline, an indicative budget even for 2021, as it were. And I wonder. I know there are a variety of variables that have been mentioned, which still haven't been finalised, clarified, etc. But I would imagine that there has to be a degree of planning already in place in terms of ensuring that you're able to take forward an indicative budget as things stand right now for 2021. 21-22, sorry, let's get the years right. Which we thought we might have been able to see because it would have given us at least a direction of travel, an indication as to how we were managing the deficit, etc., and whether that was going to continue into the following year and so forth, how that was being managed through the system. There's another question going back to Pat's point about the vacancies, etc. In the next bullet point on the issue about 2021 performance, it talks about recruitment challenges. So there's a sort of issue about keeping vacancies, but at the same time some challenge in terms of recruitment, etc. That there's a slight sort of conflict, if you like, in terms of how that point is addressed. But I would have thought overall there would have been an indicative budget that could have been referred to, and as these variables are resolved, the indicative budget is adjusted, amended accordingly, that we might have been able to see that kind of information so that we could see what the staffing budget looks like, for example, what the element of agency, commitment to agency working is built into the budget for this coming financial year, and what issues in terms of property and servicing buildings and so forth might have been built into the budget. None of that information appears to have been offered in any shape or form this morning, Chair, and I just wonder how we might be able to have a look at that, given that we might not be meeting again till June, July. 4 months into the next financial year, that we are left with, if you like, an inability to scrutinise what the budget might look like for the coming 12 months. And I think somehow we've got to find a means of addressing that rather than leaving it till June, July. Whether there's a means of looking at it between now and then.
Okay, over to you. I think Andrea, this is your question. I think.
Okay, so in terms of the indicative budget, as Judith pointed out, we are going through a planning process at the moment, as I said, and we are considering all those factors that you've said in terms of what our operational budgets may look like, and that is going through an internal governance process at the moment. So obviously that needs to go to our executive team and then through to our board during March. there have been delays. There have been delays nationally. We know that Q1 we will continue. So it's going to be a very difficult year, a very different year as well. So we know that Q1 we will be under the same regime as what we're under this time. So our budget may be different. We may have to modify our budget for Q1 depending on what we're instructed it needs to look like by the national team. So in 2021, for example, during the first half of the year, the national team told us what both our income and our expenditure should look like, and that formed the basis of the system envelopes. So what we'll have to do, as you've just pointed out, is we're working through that indicative budget process, and what we then need to do is to overlay that with the national guidance as it becomes available. And I believe now that's due. I'll look to Judith just to nod. We were expecting that sort of early March, and then it slipped a little bit further, but I believe, Judith, we're now expecting it on the 26th of March, if that's right. And a lot of those delays, I think, have been down to some of the national negotiations that have been taking place with Treasury about how long that national command and control regime will run for. So we know for definite it will run for the first quarter of the year. What we don't yet know is whether that will be extended and whether that will run, say, for the first 6 months of the year, etc. And all of that taking into consideration the things that we've talked about some of the pressures on the system and the need to recover, etc. So that's the reason why there has been a delay. And as Judith pointed out, that's some of those circumstances have been outside of our control, and that's happening across all of the NHS organisations. But we are taking an indicative budget with those variables that you've just described through our internal process during March. In terms of the recruitment challenges, I guess just to clarify, what I was referring to for the recruitment challenges is where we are given non-recurrent money. So obviously there's a limited pool of staff that we can access through both bank and agency, and we use those for a lot of our day-to-day business. Where it is really challenging for mental health is where this non-recurrent money becomes available, because then we don't necessarily have the commitment, if you like, from our commissioners to be able to offer permanent contracts, because that would leave the organisation with a significant financial risk. And that's what I was saying about some of the recruitment challenges that we've faced around where national COVID monies were made available for the establishment, for example, of the 24/7 helpline. That was non-recurrent money that ends on the 31st of March. And those challenges, and as Judith said, obviously there's an awful lot of non-recurrent money as well that we're expecting a share of, that sort of 500 million. And it's about where we balance that system risk. And that does give us a real challenge where it's a lot of non-recurrent money into mental health about how do we recruit to those posts. So hopefully that clarifies.
Right. Well, I understand that, but I mean, we could have had this discussion under Part B, not in the public domain, as it were, if that had been deemed necessary, and that information could then have been shared with us at this point, rather than simply withheld, as it appears to be at this point in time. So it does mean, of course, that we will need some kind of
if it's me or if someone's frozen, sorry.
Opportunity. There's some consideration needs to be given as to how we, how the members, are able to access the information, so that we can have a more informed discussion about how, what the future holds for the trust.
Yeah, we've got a few more hands gone up now. Councillor Pat Sullivan.
Thank you, Chairman. I think listening to both sides of this, this could go on forever. That they haven't got the information, we want the information. So I would suggest, it is a long time till June, that when things clarify, or perhaps even now, we should arrange another meeting, Chairman, just to scrutinise the budget on this. Otherwise, this discussion will go on forever and not really get anywhere. So I agree with Councillor McLaren. We need to be able to scrutinise this carefully. So we need another meeting.
Yeah, fine. That's actually what I was going to suggest. Maybe we could have a one-item agenda, because looks like this is going to get complicated. And like you say, there's an increase in demand and everything that Councillor McLaren mentioned. So maybe we could just have a meeting just to discuss this, because it is important. I don't know if that's Is that okay, Peter? Because I know we're going into
Yes, it is. Yeah, I mean, timescale. What would you be looking at? Early April.
I think, Andrew, would that be okay? No.
Can I come in, Chair?
Yeah, Judith.
So we're not going to receive the planning guidance until at least the 26th of March. That date is uncertain because it's already moved. So traditionally we get it on the 24th of December. So it's been moving with new deadlines issued since then. So I wonder if we could confirm with Peter when we're in receipt of the guidance and have an understanding of the deadlines for production of the budgets, indicative and financial plan. And then if we route it through Peter, would that be better? I'm just nervous of us agreeing a day. We're not in charge of the timetable.
I'm aware of that, and I think we all are aware of that because obviously they've been moving the goalposts, haven't they, for a while. So we are aware of that. But if we could probably get one, but we're going into Purdy, aren't we? So I don't know how that's going to affect this meeting.
No, I think you'd still be able to have the meeting, Chair.
Okay, so if everybody's in agreement, maybe we have another one beginning of June. Would that be better?
Well, we have one in June, Chairman, don't we? So,
The next ordinary meeting would be in June.
Yeah, if we could do that. If that's what everybody wants, and I think it's important that we get this information and we be able to scrutinise it properly and make sure that it balances with everything that.
Well, perhaps another way would be for maybe the chair, vice chair, and another member, say Councillor McLaren, to meet with the informally with the director of finance or chief executive to pursue it, maybe in April on an informal basis, and report back to the other members of the committee, or have a formal meeting in April. It's just a suggestion.
Yeah, I'm happy to do that. If Councillor McLaren's happy to do that.
Yeah, happy to have the informal discussion, Chair. I think we've been looking for a meeting with the chief exec for some time.
Yeah.
So perhaps this would be a suitable opportunity with Andrea, of course, and yourself and the vice chair to and we share with members.
And any other members who wishes to attend as well, maybe. Yeah.
So is that okay?
Yeah.
That sounds reasonable to me, and then we can sort of scrutinise it properly in our own time and then get to the meeting and discuss whether there is going to be any gaps or how it is going to. I'm sure it's going to affect some of the services from what I've heard. So it'd be good to get hold of that. Is that okay?
Yeah.
Thank you, everybody. So that's that. Has anybody got any more comments or questions on that item? So then we move to the next one, which is staff health and wellbeing. So who's
that, Chair? I'm leaving the meeting now, as discussed at the very beginning. So thank you for that, Chair.
Okay. So we're on staff health and wellbeing.
Thank you, Peter. So I know people will have seen the presentation before the meeting. I'll talk through some of the key highlights through it. Very happy to take any questions. Started off by just looking at giving you some information about what absence looked like during the period of the year. We had a very initial peak in absence levels that went up to about 7.5%, and that was around about April time last year, so very early days when COVID started for us. But after that, our sickness levels have remained pretty constant, around about 6%, and that's consistent with previous years. So we haven't seen a massive increase in sickness at all in the organisation, other than that initial peak when COVID started impacting on our staff. The reasons again for sickness have been very consistent. So the most common reasons for accessing additional support or occupational health and staff wellbeing services have been stress, anxiety and depression, musculoskeletal injuries, and that's common with previous years. In addition, this year there's been, I suppose, a growth in that bereavement and loss as reasons for accessing additional support. And some of the sickness increase has been around people with COVID taking time out of work because they've actually had COVID themselves. In terms of staff having to shield, so it's a bit of a flexible number of staff, and it depends on the guidance that's been announced nationally around who is required to shield. But we've had approximately 35 to 50 staff shielding and unable to work. So because of the flexibility in some roles about being able to work from home, lots of staff that were required to shield were able to continue to work from their home base rather than needing to come into work. So that figure relates specifically to staff where alternative employment couldn't be found because of their need to shield. So their job only could be done if they came into the workplace. Okay. Thanks, Peter. Thank you. I think the sickness levels hide I suppose the feelings of staff and the impact on staff. So sickness levels for us remain pretty consistent most of the time. The actual workforce pressures are slightly different and probably give a bit of a bigger picture about the impact on staff and around their well-being. So particularly now in the third lockdown, I think consistent with the rest of the country, there's a lot of staff fatigue and there's a lot of concern for their burnout, having worked for such a long period of time now in those challenging conditions. We have different pressures to acute trust. So one of our pressures is that on our wards in the community, we've obviously not got patients who are in a bed. So particularly on wards,
Is it just Fiona that's gone?
The sound's gone.
Sorry, I just disappeared completely then.
Yeah.
I'm back. Can you hear me again? Sorry.
Yeah.
Yes.
Yeah, you're good now.
So one of the pressures that staff have been facing is that difficulty in maintaining social distancing for our service users who are on wards. They're not in a bed and maintained in a bed. People are mobile, so that provides additional challenges. And understanding that pressurised environment where there's no visiting or leave allowed for any extended periods. So in our wards particular, there's been a lot of pressure on staff and on our service users around being able to work and live in that environment. And the emotional toll for our service users who may not have been able to see anybody provides additional emotional toll, I suppose, on that work environment. And then for our staff that aren't based on wards, there's been the additional pressure of staff working from home and running remote consultations, and for staff shielding who may have less contact. So there's been a range of pressures across the year, which I think we're seeing as a general fatigue in our staff, but also that concern around burnout. And that's not been reflected in our staff sickness levels. Thanks, Peter. Could you put the next slide up? So what we've been doing over the year is being really mindful around what is the support that we can give and offer to staff to enable them to manage that burnout and the fatigue levels that they may be associating. So all staff were provided with a robust risk assessment to look at what specific needs they may have. So in some situations, that's looking particularly at staff who are more at risk. So our BAME staff group, disabled staff group, and the risk assessments were updated each time there was more national guidance given about the unequal impact of COVID on different groups of staff. In some areas, we've put in things like wobble rooms so that there's the breakout room for staff to access. Peter, would you mind just going back to the previous slide again? Thanks. We've provided lots and lots of resources. So we've been able to do a lot of from home, provide virtual sessions and support from staff. So we've run some and continue to run virtual resource sessions for staff, including personal resilience and wellbeing, connection events, looking at how managers can support staff who are working from home, how to manage virtual teams. But we've also been putting in place the peer group support. So for staff who are shielding, to enable them still to connect, putting in place coffee connection events to allow people that opportunity to network. Thanks very much, Peter. So we're providing regular Q&As with our executive team on a virtual basis, so people can dial in and connect and talk to senior managers across the organisation. We've developed a hub on our intranet with a wide range of health and wellbeing information. And then the NHS nationally has provided a huge range of resources this year, which have been really valuable. So there's been access to free apps for staff focusing on things like sleep, mindfulness, bereavement, anxiety. We've been promoting the access to the national helplines and resources, common rooms for networking events and training programmes. Back in September, we ran a big thank you week to recognise all of the work that staff have put in so far across the year around continuing to enable us to provide services. And that was really well received across the organisation. So we promoted each borough on a different day during the week, looking at the amazing things that staff had managed to achieve. There were visits where possible from senior managers out in the organisation, and a thank you letter and card to all of our staff. We're really fortunate that the NHS have put in place trauma support centres across the NHS, and Greater Manchester were the first to put that in place, and we're really fortunate that we host that trauma centre. So that's the GM Resilience Hub, and staff have been able to access that centre, as well as our staff wellbeing service that already provided psychological support for our staff. So we've also been part of the Northwest Clinical Leaders Network support, which has been looking at the ground level, what's the environment that leaders can put in place that enable people to maintain their well-being in the workplace. We've just got our NHS staff survey results. So this is an annual requirement for all NHS trusts to complete. And the results were published on the 11th of March. And we've seen some great improvements in health and wellbeing over the year. So it gives us an indication about how our staff are feeling about the proactive nature of the health and wellbeing support that's been provided to them. So, and some of them are obviously, there are some benefits from COVID, aren't there? So we've seen that there's been a 5.5% increase in staff saying they've been able to access flexible working practices. So for staff that have been working from home, they have found that quite beneficial in some circumstances. We've had a decrease in staff feeling pressure to come into work where they didn't feel well enough. And that's quite a significant decrease. And when we look at where does the pressure come from, in the main it comes from ourselves. So we feel that we have to be in work when we're feeling poorly. It's not coming from managers or other colleagues, it comes from ourselves. But there's been a decrease in people feeling that they had to come into work. A decrease in staff saying that they felt they had unrealistic time pressures, and a really good increase in staff feeling that the trust has taken positive action about health and wellbeing. Okay, so those were some of the key things that we've done across the year to try and support staff in the workplace. Just mindful of the question that came in earlier around volunteers and what we've done to support. So I think it's an interesting picture, isn't it? Going back around that huge demand for volunteers across the NHS to support in COVID. The support that we looked for and were particularly interested in was qualified nurses who wanted to return and work in our workplace. And we were particularly interested in mental health nurses who may have retired or left work and taken up different opportunities to come back and work on our wards. I think we were not able to identify more than 5 people who actually wanted to come and do that for us. So in terms of the picture about that national drive around volunteers to work in the NHS, for us as an organisation, we didn't benefit out of that national drive. But I think also a lot of the volunteers were for outside of acute type services. They were looking at setting up local services in areas rather than going into hospitals or mental health services. Where we did have people who were interested in retiring and returning, we put in place a preceptorship and mentorship programme to support those people so that they didn't feel that they were suddenly into the frying pan. And we also looked at redeploying staff from different areas within the organisation. So Andrew mentioned earlier about corporate services staff, headquarters staff being able to go out and support. And again, we put in training programmes to support them to relocate into working in a different area. Happy to take any questions.
Yeah, thank you. Can I just say, I think it was Councillor Surjan who asked that question. So can I just ask, is that okay? Is that response all right for you?
Yes, that was, and I think, yes, thank you. It was a lot more in depth. So thank you for that presentation.
Okay.
Thank you very much.
Yeah, thank you. So Councillor Pat Sullivan. You're on mute, Pat.
Sorry, I just said, just call me Pat, Susan, or Lady Patricia.
It's just on screen, it says Councillor Sullivan, and we've got
I know. Just a question, Fiona. I'm very interested in what seems a very upbeat presentation indeed, but what we hear on the news is nothing like that. And I'm just curious to know if other trusts are doing as well as you seem to be doing, because obviously that questionnaire at the end for staff is very positive.
Our national survey's results are measured against all other like trusts. So we're measured against mental health community trusts, learning disability trusts, and all of those trusts have seen a slight increase in staff feeling that their wellbeing has been supported more proactively during the year. So that we are like other trusts in the way that we've been able to improve the perception around wellbeing during the year. I think what's presented in the news quite often focuses on the really high pressure ITU, A&E environments. And our pressures are similar but different in that we don't have the numbers of people who are seriously poorly. So although we are looking after patients who have COVID, it's not to the same extent as you would see in acute hospitals. I do think the sickness absence levels mask the fatigue levels and burnout levels that we are seeing in our staff group.
Yeah, I just hope that maybe it's not relevant to us that in these acute wards that they are getting the same kind of support as you're giving. Thank you.
Yeah.
Judith?
Yeah, we've just on that point, we've recently done some work for some information that's going to the North West Regional team, because there is some anxiety that the positive results in the staff surveys, Fiona said, and our sickness level, and I just checked before this meeting and it was 4.9% on Monday, which was the lowest since August. So that willingness to come to work, to join in, to muck in and be flexible, it's been extended now for so long that there is a worry about the underlying impact and a point at which some people might tip over. And what we're trying to work out is what other measures could we use that would indicate the pressure that our staff face. So we're not in ITU, as Fiona said, we don't have some of that end of life experience that must be so traumatic, but actually in an environment where even taking swabs for COVID tests is very challenging for our client group, and we have distressed patients, trying to maintain distancing when people are moving about all over the place and out in bed. They're just different pressures, and we're struggling to get some metrics that would capture them, but we are working on that. One of the things we're looking at is acuity of presentation, number of people under section, for instance, within the population of inpatients. So we're trying to see if there's any other way to capture the pressure that staff experience.
Thank you.
Anybody else?
Councillor Davis wants to ask a question.
Councillor Davis next, is it?
Thank you,
Yes.
Chair. I've not worked in the NHS. I'm a bit of an amateur in this area. I'm very the staff survey results are interesting and look relatively positive, and so I'm quite impressed with that. And lots of work seems to be done. Just I've got a sort of trade union background in the sense that I was part of a trade union in education, and one of the things that we when I was working was that I think it's important that trade unions are represented, and feedback can be slightly different. And sometimes people can say things to their unions they won't say even in a staff survey, let alone to management. I presume that the trust have representation from trade unions and take into account, because I'm sure they do represent some of the issues about the well-being of staff, and you get feedback on that basis. I'm slightly surprised that it's not referred to here, but it may just be the protocols you use. Thanks.
Yes, we do have trade union and staff side professional body representation. We meet regularly as a formal meeting to look at representing views of staff across the organisation. But we also have a health and wellbeing group, and our staff side chair is a core member of that health and wellbeing group. So in that group, we work to look at what might be some of the things that we could put in place to support staff during the year. And what we're starting to work on now is what would our recovery planning look like? So bearing in mind the fatigue levels of staff, what are the things that we need to put in place this year to enable people to maintain their well-being during the year? So our staff side chair is a core member of that group.
Thank you. Thank you, Chair.
Thank you, Chair. Councillor McLaren.
Thank you, Chair. Two things. There's no reference in here. I'm just wondering what progress we might be making towards getting to good during this difficult period, as it were. Whether that journey is still ongoing, and whether there are any issues that might still need to be addressed, by the trust, etc., in order to achieve good, as it were, and how that might be reflected in work processes, budget challenges, etc., at this point in time.
I think Judith might be better placed to answer that than me.
Got her hand up, yeah.
I mean, notwithstanding that, some of the methodology for rating trust is changing in terms of what the CQC are looking for. We've still continued with our journey of improvement, and one of the main features of our Getting to Good programme was actually the elimination of the sort of promotion of single-sex environments and the eradication of dormitories. We've done a considerable bit of work. I don't know if it's been fed back to the previous meeting about eradicating dormitories. We attracted some capital funding. There's work ongoing at the moment on our Birch Hill site. So we will eradicate the dormitories, which was one of the issues that capped us with our current rating. We also had mixed sex accommodation, and we've got a programme to move to single gender, single sex accommodation. I don't know if you've had a recent update at committee, apologies, I don't normally attend, but we can certainly, and we've made really, yeah. So I think those two things are key parts of Getting to Good, and then everything else has continued in line with a sort of continuous improvement journey around board meetings, governance, etc.
Yeah, thank you. Thank you so much. So is that everybody's, there's nobody else, I don't think. Is that right, Peter?
Yes, so, Chair, yes, nobody else wants to speak, yeah.
I was just so surprised then with the positive outcomes of that. But it's good that you're looking into into it in more detail. So I know it's positive and it's great to have positives, but you're aware, that maybe that's not really reaching some of the people who you want to hear from. So I'm happy that you've actually picked up on that. And so thank you. So we'll move on now to the next agenda item, which is the impact of COVID-19. Don't know who's doing this one.
I'll do this, Chair.
Thank you, Judith.
So I've just picked out some headings around the impact of COVID-19 and what that's meant in terms of our service delivery. So if I run through and then we can pick up questions at the end. So actually, we've had continuity of service delivery throughout the pandemic. We've recently been reviewing some of this time period because it's virtually a year since lockdown commenced. But we did have to suspend some group sessions work for distancing reasons, some memory assessment and day hospital services based on infection prevention and control measures. And they were stepped down both in lockdown 1 and 2, but now are actually remobilised within COVID secure guidelines. So we've managed to continue some sense of service delivery actually throughout Pennine Care services. We had, through the life of the pandemic, had inpatient services that have experienced sustained high occupancy levels, and we have a reported increase in complexity of patients. And because of those high occupancy levels, we've had a significant push to look at early and appropriate discharge and done quite a bit of work on delayed transfers of care in collaboration with colleagues across GM, but also in collaboration with our partners in the system to facilitate early discharge. As I mentioned, we've got quite a lot of progress on our dormitories and single gender accommodation. And in our community and primary care psychological therapy services, we've had a significant switch to remote consultation. But I think it's worthwhile just sharing the fact that face-to-face contact was never suspended for our community services, but always carried on based on urgent need and risk management issues. And as I mentioned previously, although the referrals reduced overall, the activity levels have remained the same. So we've managed to see the same amount of people that we ever did. And we also in that time developed the 24/7 helpline. And we've been able to be flexible and move staff around. I think as either Fiona or Andrew mentioned, we've had staff who were shielding, but who could man telephone helplines. And that's helped us maintain service overall. And that's one of the reasons I think that we haven't seen any particular budget pressures. Oh, I think we're going backwards. Sorry, Peter. So during the pandemic, we've managed some innovative approaches to service delivery. I'm just going to move my dialogue box because it's blocking out my slides.
It's okay, finished, got it.
Thank you.
Thank you.
So we've got lots of developments, and one of them, for instance, is the depot clinics where people who need regular injections for their medication. We've now tried to do some depot clinics at home where it's been challenging for people to come into service. Within our acute trust footprint, we've refocused and physically moved some of our hospital liaison services with support from our acute trust so that we don't have distressed people or too many people routing through the A&E front door. We've done quite a bit of in-reach work with focusing on supporting patients with mental health needs in the acute trust and helping them also to reduce hospital stays and support early discharge so that the hospital doesn't become overwhelmed. We've done quite a lot of work with our LD services because there's been nationally, I think there's quite a lot of information about how disadvantaged learning disability clients have been throughout the COVID pandemic. So we've been looking at that and ways to support. Fiona mentioned the Resilience Hub, which is supporting staff across health and social care settings. And then in a couple of our boroughs, but in Oldham in particular, we're looking at the development of services for long COVID with some joint work with psychological medicine services to working with people, partners in the acute trust, about people who seem to be impacted longer term. We've got quite a lot of digital approaches that we've adopted to visiting mental health at tribunals. I know we took part in virtual inquest hearings, so we've really had to change the way we work to support the system. And aside from the 24/7 helpline, we've had some locality helplines developed in some of our localities. So we talked previously about demand and how able we were to predict that. But just to pick up on what's happened with demand, the level of inpatient admissions hasn't decreased. And we did quite a bit of work about our bed capacity and supporting infection prevention and control processes, and we still remain with a very high bed occupancy. It's about 90%. So there's been no change really in that pressure within our inpatient services. I know within other services, the demand's just disappeared. That isn't the case for our inpatients. We've had some real peaks and troughs in terms of demand for our Section 136 places of safety detentions, where people come in usually via the police. But we've had, I think, although that's gone up and down in peaks and troughs, our police colleagues are reporting that actually there's a sustained and significant increase of their work that relates to people experiencing mental health problems and crisis. In terms of the people who come into our hospital, we've noticed that there are increasing admissions for people who weren't previously known to our services, and to people probably who were known to our services but were stable pre-COVID and then have had a deterioration of condition during the pandemic and particularly during lockdown. Within our inpatient areas, we've got increased numbers of people needing psychiatric intensive care services, and that is a problem across the North West and nationally, sort of an indication of people's level of illness. As I mentioned about the community services referrals, not yet at pre-COVID levels, but a couple of places where they've gone up. In child and adolescent mental health services, significant peaks following returns of schools. And I think really it's fair to say that very few schools have had all the pupils in for any sustained length of time. So we do expect that to continue. Our crisis teams have been working more in an in-reach way, with a significant focus on supporting early discharge given the pressure on our inpatient wards, but obviously as appropriate where support's available in the community. In terms of our ongoing performance for psychological therapy and early intervention, we've met the access performance requirements. So despite the pandemic, we've continued to meet the requirements for those services. And we're now working very hard to recover some memory assessment services and get over the impact of lockdown. And I know we've got initiatives such as virtual meetings and support groups for carers that we're facilitating. I wondered if it would be helpful, as well as a sort of indication of the sort of things we've been doing, and please give me any questions at the end if this isn't level of detail. But one particular thing we wanted to highlight was a vaccination update, because we established at speed a vaccination hub within our trust headquarters building in Ashton, and we managed to transform a non-clinical area into an infection prevention and control safe clinical environment in a matter of days, really. And that's I've worked in the health service 35 years this year. That's the fastest I've ever seen anything set up and running. So it required significant effort on a lot of people's behalf. We managed to give bespoke additional IMVAC training to our mental health staff for all the delivery models for AstraZeneca vaccination. We've got PGD training, apologies for the acronym, even I don't know what that is, that's my bad, sorry. But we've got competency sign-off. And for mental health staff, although quite a lot of our staff have dual qualification and are qualified nurses, issue of vaccines isn't a routine day-to-day thing. So even our doctors had to undergo further training in order to be able to volunteer to vaccine staff. We did use a lot of support admin right across the patch to manage our vaccine hub, and we did use some volunteers for meet and greet because we had to repurpose the building and change it to a one-way flow system. And I guess we've promoted our vaccine really significantly amongst all our staff. So in terms of numbers, we have about 3,500 staff, and as of last week, we had 2,876 of those staff vaccinated. So we're running at about 80%. And we've now commenced some vaccination activity within our inpatient areas and have delivered vaccines to 103 patients. And there are complexity of vaccinating patients who are within in one of our inpatient areas where they're going to have a certain level of distress and illness anyway. It's actually quite challenging, but we're working our way through that. So some of the service pressures that we've experienced across the pandemic, we've had increased out of area placements where actually we are so full in our inpatient area that we don't have a bed. And actually that isn't just us, Greater Manchester Mental Health have the same pressure, and it's the same pressure across the whole of the North West and nationally. So there's severe shortage of adult acute male inpatient beds and also male psychiatric intensive care beds. Greater Manchester Mental Health are supporting a piece of work for the region about how we might, via the independent sector, procure some additional bed capacity because the demand outstrips the capacity at the present time. As Fiona said, we've got some concern about staff burnout and fatigue because of that continued willing to compromise, work hard, be flexible. There's a sort of probably a limit to that before people become exhausted, and we're working very hard to work out how to support that. And I mentioned that we've not got the detailed modelling on surge in mental health activity, but we're working collaboratively to get some of that. I think patient choice to be seen face-to-face is increasing. So whilst we've never suspended face-to-face interventions in the community, actually the percentage of people that we're seeing face-to-face has increased. And I think that's a patient choice issue. At the beginning of the pandemic, I think people were naturally anxious and frightened, but as time's gone on, more and more people are now asking to sit for a face-to-face appointment. And we're very aware that remote technology and virtual appointments don't suit everybody. And one of the concerns, I guess, that we've got, which is a general concern, is about that digital literacy and that social inclusion. So really face-to-face remote consultations don't work if you've not got the technology, something we need to look at. We do have some people still waiting for service because people who refused a virtual visit at the beginning of the pandemic, and that's mainly for psychological therapy services. We're trying to work through that list of patients now and check if they're feeling any more secure and would like to access that service more quickly and more frequently than face-to-face visits. And we're working to re-establish bits of service that we can't deliver virtually, such as physical health check for patients. So that's a quick run through of the impact on COVID in terms of what we've done in terms of service delivery, what the demand experienced has been, and where we think we've got some pressures. And if this is of use, I don't know if this is too much detail, but we did on Monday, I had a look, and we only had 13 staff who've tested positive for COVID as at Monday, and one person self-isolating. So we have managed through the pandemic, I think, on goodwill, but actually not with really well-managed sickness and a continued support of our staff. So there's no particular service reduction because of availability of workforce for us.
Thank you, Judith. We've got a question from Louis. You can't hear you, Louis.
Okay. Hi. Sorry. I was having a feedback issue. So I'm assuming. So just to ask then, because obviously you still got 720 of your staff to vaccinate. Is that are the majority of those the first ones who you've vaccinated, or are some of those now your second vaccinations? Also, in regards to some of your inpatients as well, just a quick question in regards to the recent reports of the do not resuscitates. Have you actually had any experiences regarding any do not resuscitates in your own trusts, or has that not actually happened within the trust here? So I just wanted to ask those two questions, please.
Yeah. I'm not aware of any incidents, but I wonder if that's a question I can take to our Director of Nursing. That's discussed by Quality Committee. I don't attend Quality Committee, but we can get an answer to that question. I think that's more a care home issue than within secondary care mental health services, but I'll check that out for you. Yeah, we do have still a number of staff who haven't been vaccinated. One of the things we're trying to confirm is via a national system, within that number that haven't been, have some of them actually received a vaccine in another environment via a GP clinic or one of the, the sort of big vaccine hubs. We're reasonably clear where our staff have been vaccinated via an acute trust, but we've still got to do some refining of the numbers. Having said that, we know we've still got staff who haven't received the vaccine for one reason and another. So we're doing quite a lot of promotion, and we have since the start, on more difficult to reach group or groups where people have vaccine hesitancy. So we know for the numbers last week, there are lesser percentage of take up amongst females and amongst people from BAME communities. And I think that's more exacerbated in our younger staff age group than older groups. And so we're still working through that. So we've got individuals who represent those groups promoting stories. Fiona might want to come in with some of our trust communications. We're supporting one-to-one conversations via managers. We're asking managers if staff need to drop in and explain anything. We've got a variety of means of communication to really discuss with people if they do have a vaccine hesitancy and find out why that is, because there'll be a percentage within that number who may not be appropriate to receive the vaccination. But it's an ongoing thing. I don't know if Fiona's got anything extra to add.
I think you said most of it. We've also done some big myth busting sessions. So as well as the promoting through our newsletters, some myth busting, we've also done some virtual sessions with some of our medics to talk about the myth busting around the vaccine. And our risk assessment process for this year is being updated to include some questions that help managers have that discussion with members of staff around that hesitancy, if that exists for some of our staff groups.
Is that okay, Louis?
Yeah, that's fine, thank you. Sorry, I'm on mute, and I do keep having some small Wi-Fi issues. I might keep disappearing and popping it back on. Then I can't hear what somebody's saying for a bit, but I'm getting through it. So thanks for your patience. Pat, Dale?
Thanks, Chair. Judith, you mentioned actually at the beginning of the session that it was when we were discussing the budget, that there is a lack of modelling out there, which is clearly very concerning, because without the modelling, how on earth can you make a plan, or how can you plan for the future if you're not sure of what you're looking at? Now, you did mention that you have started some work within Greater Manchester on modelling. When do you think you might have the results of that? Because obviously that's going to be crucial in terms of, for example, deciding what your recruitment has got to look like. If the pressures are going to, which they will be, if the pressures are going to be higher than they are now, clearly that will mean we're going to need more staff. So if nationally there is a lack of modelling going on, I'm pleased that there is some going on in Greater Manchester, but it needs to be going on at a pace. We need to be looking at this in the round quite soon if we are going to put plans in place. Does that make sense?
Yeah, so we did some modelling as part of phase 3 planning, and in the absence of any guidance, I worked with my colleagues in Greater Manchester Mental Health, and we did some modelling based on percentage increases to, can people hear me? Some of my screen is frozen.
Yeah, I can hear you.
Yeah, we can hear you.
Yeah.
Now she's frozen.
Frozen now.
Must have had a premonition. Just wait a couple of minutes, see whether she comes back. If not, can you catch up with that, Fiona?
Yeah, I'm sorry, I don't know enough detail to be able to talk about what Judith was going to talk about. I'm sorry, but if Judith doesn't get back on, I can feed back that question was still outstanding. Yeah,
if you don't mind, because I think she was just going to get into the modelling that's taking place, which I think Pat was trying to get at, so we'll just give her another couple of seconds because she might be trying to get back on.
Chair, I just really wanted to know if we had a date, when we as a group could look at this modelling and, make some recommendations or some comments about, what it's going to mean for the future, because that's what we should be doing now. It's looking to the future. Have we learnt lessons from what's happened in the past, and how are we going to make sure that, to use Build Back Better, that has got to be something that we need to be looking at, very seriously.
Judith is back. We waited for you, Judith, because it's so
sorry, me off on purpose.
good question, so I wanted to know. To wait.
Yeah. So the initial modelling we did, we said what if demand increased 5, 10, 15%, and then we worked out what increased capacity we'd need. And I guess it's unfortunate that actually, with the exception of inpatients, we haven't experienced that increased capacity. So we're trying to do that again, but it's more complex than just what would the increase in demand be, because quite a bit of our service delivery has changed. So where we've got a combination of remote consultation, sometimes that's just telephone, sometimes it's video consultation and face-to-face visits. I don't think we'd ever return to the percentage of everything being face-to-face, because actually there were some quite good outcomes reported in terms of convenience and flexibility for patients. So we're having to try and balance, if the increased demand looked like this, how much of that demand could we meet because we're now working differently, and what's the outstanding gap? And that differs by service to service. So that's some of the complexity we're trying to look at. But even when we get to predicting the demand, then for us to be able to recruit more staff to meet that demand, we would have to be commissioned and funded to do that. So it is a really complex picture. So there's the non-recurrent money that's available this year, which is about restoration and recovery of service. But I think this demand will extend beyond 21, 22. So it's just an ongoing piece of work. And I don't have the answer, and it's really difficult. And I think the demand, the increase in need in the community, some of it will be met by secondary mental health services. But I actually think the VCSE sector are well geared up to support some of that demand.
Yeah.
And we need a sort of variety of interventions right up the pathway, and not leave people to the symptoms exacerbate and they end up in secondary care then. But we haven't even got the planning guidance. When it comes, we're going to look at what can we predict for demand. But generally speaking, in previous years, for mental health services, there's been much less focus on activity than there is focus on activity with the acute trust. So it's kind of a constant battle. So, it's really helpful to have the support of joint oversight and scrutiny in terms of asking these questions. That allows me to feed that back into planning. And there's a general concern about a demand increase and not particularly a plan to meet it.
Thanks, Judith.
Thank you, Judith. Is that okay, Pat? So, and I can't see any more questions. I'm going. Okay, so Peter's had to. Are you going, Peter? Are you having to leave us, Peter? I mean,
no, it's Councillor Hamlet that's leaving us.
Oh, sorry.
Yeah.
I can't see properly with my screen. My screen's gone little as well. Everything's going wrong, but never mind. So that's the end of the meeting, as I can see. I mean, I was so surprised at the positive outcomes when it comes to staff and health well-being, and I'm guessing, obviously we're going to have to get more resources and more funding because of long COVID, and long COVID is affecting people's mental health even more than it's affecting people's physical health. And don't forget those who are logged with physical, physical things that's wrong with them. They're also suffering with the mental health. So I can see that it is going to be a bit of a struggle, even though it's not too bad of a picture that we can see at the minute. But you're right, Judith, if we're here as a scrutiny panel, and that's what we want to do, scrutinise the services and make sure that you're getting the, because it's always been the Cinderella of resources, I feel mental health. It's one of the reasons why I wanted to come on this committee. I mean, we're in good hands. You're doing what you're doing your jobs and everything, but some things is outside your control. I think that's come through with this meeting. So if there is anything else that you feel that we could help you with, I did put a motion into the council to ask the government for more resources and more funding. The picture wasn't too bad when I did that, but I could see, like you have got, Judith, the picture's going to get worse, especially with long COVID. So we're all in it together. So we scrutinise for reasons, for our personal reasons to find out what's going on, but it's also for the public out there as well, so they can see that we're doing our job and you're doing yours. So there was some really good questions today. I mean, I had quite a few written down, but everybody sort of covered them. So keep up the good work, and our thoughts are with you all the time, because we know it's hard times for mental health and for the NHS in general. And let's hope you get your pay rise, what you're entitled to. You know, for me, you should double your money. Here for that one, yeah. I think for me, you should double, but we know the government have got to then find that money, but they find it for other things. So I think the NHS is so important. They should be at least be given a decent wage for recognition for the work that they've been doing throughout the years. So thank you. Everybody's agreeing. So you've got our support. So thank you, everybody. I think that's the end of the meeting, except for the date.
I'm happy to endorse your comments, Chair.
What's sorry? Somebody says.
I think we're all happy to endorse your comments.
Oh, thank you. Thank you so much, everybody. So the date of the next meeting.
I think we might be best leaving the date of the formal meeting, because some members, I'm sure, in this room now are subject to elections on the 6th of June, 6th of May rather, and there'll be annual council meetings as well between now and then. But we did agree to have an informal meeting, didn't you, on at some stage in April when the information is available. So if Judy or staff can make me aware of when that information is available, then I can contact members and we can set up an informal Zoom meeting perhaps, which isn't covered by per the regulations, if that's okay with the committee, that is.
Yeah, thank you. So that's the end of the meeting. So we'll see you soon. Thank you, everybody.
Bye,
everyone.
everyone.
Bye.
Thank you.
Bye.
Thanks, everybody.
Bye all. Bye.
Bye. Bye.